Okay, in this recording, we're going to talk about routes of drug administration. And you can see you have a lot of objectives that you need to be able to explain and identify and demonstrate. So when we go into drug administration, what it is all drugs or medications are potentially harmful. So never become casual or careless when administering drugs or assisting with drug administration. So a patient can turn on a dime that's had the contrast 1,000 times and you give it 1,001 and they have a full reaction. So never assume that the patient's going to be fine. So the radiographer must remember that contrast agents are drugs and the precautions pertain to these agents as well. So contrast has to be locked up. It is pharmacy comes in and does counts on them. We have to keep track of every bottle that we have. So before giving a patient any medication or a drug or contrast, the imaging technologist should always adhere to the 6 rights of drug administration. Now I know your book says 5 rights, but it's actually 6. So, we'll talk about which one they missed. So know the patient has the right to refuse the medication. So every patient has a right to say, I don't want that. And you need to say, I understand, and you need to honor that. So the imaging technologist should never force a patient to take a drug and consult with the physician immediately if the patient does refuse and they really do need it. So, definition. A route of administration is the pathway by which a drug, a fluid, or a substance is brought in contact with the body or a target organ, dependent on the form of medication. So here is your 5/6 rights of drug administration. The one that they miss is the right documentation. So when you're given medication, regardless of the type of medication, you must always follow the 6 rights. So each time you administer medication, you need to be sure it's the right patient, the right drug, the right amount or dose, the right route, the right time, and the right documentation. So in your book, they missed documentation, so I have corrected that because you have to document it. If you didn't document that you gave the drug, you never gave the drug. So make sure you document that you gave the contrast. All right, dosage. So the usual dose and safe dose range for each medication is included in the package insert. If you guys have looked at the package inserts, oh my gosh, they're huge. They unfold into this big, huge 3x3 and foot, piece of paper, and the font is teeny tiny. So you can look on there. You will see what is the recommended dose. I have looked at that before to see what the recommended dose is compared to what we're giving. So physicians are not required to prescribe the usual dose and may specify a different dose for very good reasons. But when an order specifies a much higher dose than normal, be sure to verify the accuracy of the order. When medications or contrast medium is approved for pediatric use, the recommended pediatric dose is according to the child's age and or weight and will be stated in the package insert. So on kids, I will look that up. So routes. Drugs are administered in a variety of ways. So there's oral, sublingual or buccal, topical, rectal, parenteral. We have intradermal, subcutaneous, intramuscular, and intravenous. And we are going to work with the intravenous. But you need to know the other types just so if the doctor says that we are going to give a topical cream or a rectal whatever, you know what it is. All right, oral route is the most common method of drug administration. It's available in liquid tablet capsules, safest, the most economical way, and it's usually absorbed in the small intestines. And it's given, drugs given via oral route are generally slower and less effective than parenteral route. Drugs given orally, patient must be conscious and the head elevated to aid in swallowing. So sublingual or subbuccal, so it's placed under the tongue or where the epithelium and capillaries absorb it, and it's absorbed quickly, so it gets into the system really fast. So it does not transverse the liver and are unaffected by gastric and intestinal enzymes, thus the drug potency may be enhanced. So usually it's really quick. Subbuccal is a tablet held in the pocket between the gums and the cheek for dissolution and absorption. So, drugs must dissolve readily in order for this to work, and the patient must be able to cooperate. The drugs should be swallowed. The drugs should not be swallowed, and taking a drink must be avoided until the drug is completely avoided. So the most common that we do this with sublingual is the nitroglycerin. Topical. So, we put it directly onto the skin or the mucous membrane. Drug diffuses through the skin or the membrane is absorbed into the bloodstream. So that's what they are. Rectal. Pretty self-explanatory, but rectal administration can be advantageous when the stomach or is traumatized or they keep throwing up and we can't keep anything down. So the medicine has an objectable taste or odor, we'll give it rectally. And when the drug is also changed by digestive enzymes. So it's a suppository drug. Vehicle is superior to retention enema vehicle because the drug is released slow, steady rate to ensure the prolonged effect. All right. So looking here, supplies. What supplies are you going to need? So drugs are injected into the body with a plastic syringe. So plastic syringes are disposable after one use. So we always use disposable syringes, and it has three parts. There's the tip or the hub where the needle attaches. So that's just where the needle slips on. It's either a slip or it's a threaded catheter, threaded piece where you can twist the needle on. So the barrel where the calibration scales are printed, and a plunger is the inside part that fits into the barrel. Parts of the needle. So needles used for injection are made of stainless steel and may not be disposable. The needle has three parts. There's the hub, and that's where it attaches to the syringe. The cannula shaft is the length of the needle metal part. So this whole piece is the shaft. There's a bevel, it's the slanted part of the needle, and the lumen, which is the inside. All right. Parenteral. So it's administered by injection. Four most common methods for parenteral administration is intradermal, subcutaneous, intramuscular, intravenous. Intra-arterial injections may be seen by technologists for certain medical procedures, so we'll do that in the cath lab or in IR. And it's usually performed by a physician. We will not use an arterial stick. So looking at the different ways that we get to the area in which we're injecting. So there's intramuscular, which is going to be a 90 degree to the skin. Subcutaneous is going to be a 45 degree. Intravenous is a 25 degree angle, and intradermal is a 10 degree angle. So as you can see, the needle going to the different areas in which we're talking about. So really important that you know that the intravenous angle is 25 degrees. I'm not sure if that was on the exam, but I know it's on your quiz. So drugs administered, including injections, using a syringe or a needle or catheter in a container. Drugs must be sterile, readily soluble, absorbable, and relatively non-irritant. Can be most hazardous route by which a drug is given. So administration requires specialized knowledge, aseptic technique, and skills to ensure safety of therapeutic effectiveness. So once you inject a drug, it acts rapidly and is irreversible. So an error in dosage or method on site is not easily corrected. You can see here intradermal, this is our normal TB when we get a TB done. So you can see they're using a TB, we call that a TB syringe, real small. And it just goes into the dermis, but not the sub-Q. And you pull the skin taut when you do it. Subcutaneous, so the surface should be cleaned and the syringe held at a 45 degree angle. The left hand pitches the arm gently but firmly. When the needle is inserted into the sub-Q tissues, the arm is released and the solution is readily injected. Based on the patient's condition or medication administered, judgment may be different angle or approach to that. All right, intramuscular, so IM, it's a deeper injection. made into the muscular tissue. When a drug is too irritant, it may be given sub-Q, although irritation may occur, some drugs are given IM. So larger doses can be given to IM and rather than sub-Q. In the cases of circulatory collapse, so shock, IV injection is preferred over delayed absorption of sub-Q or IM. Okay, so if the patient is going into shock or is in shock, you need to get it into their bloodstream, not into sub-Q or IM. All right, so IM method, essential to locate appropriate landmarks to determine the safe areas for injections. So IM injections can be given into the gluteal region of the lower back, provides the slowest absorption, the deltoid area, and the anterolateral thigh, which I've never had in my thigh. It's interesting. So the fleshy part of the buttocks is not logical for IM because underneath centrally is running the sciatic nerve. So you do not want to damage the sciatic nerve because it can cause paralysis. So avoid that area. For the IM injection, the needle of the syringe assembly is held as if it were a dart. Nice, huh? While the other hand stretches the skin of the injection site taut. So if the muscle mass underneath the injection site is inadequate and accommodate the length of the needle, the flesh may instead be pinched up before the needle insertion. So injections should be perpendicular to the skin, so at 90 degrees with a distance of 2 inches. So if possible, the needle should be inserted its full length, and a small portion of the needle should be left accessible above the skin so the needle might be retrieved should it break off, which is not good. All right, so intravenous. So IV method, direct injection into a vein, which is intravenously, is warranted, so immediate effects of the drug and or fluids are desired. Most emergency drugs, sterile saline and dextrose for dehydration, chemotherapy, radiopaque contrast are introduced through the IV. So most common IV sites, you're going to have to know this. So you have the basilic or the cephalic veins on the back of the hand, so we'll use those. The basilic vein on the medial anterior forearm and elbow, yep, and the cephalic vein on the lateral side of the forearm. So the anterior recess of the elbow where these veins are located is often referred to as the antecubital space. So you'll hear me say, go antecubital, go antecubital. You know, look antecubital. They're there. You just may not be able to see them, but you can feel them. Okay, so these are the veins that we use typically for venipuncture. You look at the hand. These are real deep. These are superficial veins. They're very shallow. We look here. You have the dorsal venous arch, and within that, I'll go in this guy right here, which is your cephalic vein of the hand. So that's a good one right there. It's nice and straight. And I'll even hit this one right here. And this one is usually pretty fragile. So you can get in here. You need to use a real small needle though. And they're very fragile. They'll burst as soon as you hit them. So you got to be careful. Okay, so if we look at the forearm, we have the radial vein. And that's a good one. That's you'll see that I'll recommend you go with the radial vein quite a bit. Coming up, I don't like any of these forearm veins. They're usually pretty deep, although they look good and you're like, oh, I can see it, I can see it. As soon as you put the needle in it, they explode. So I don't like to use the forearm veins, so I'm not going to let you guys practice using the forearm veins. We're going to use the hand, the wrist, and we're going to go antecubital. So if we look here, coming up, we have the median vein of the forearm, and you can see it's nice and straight. So here's the elbow. So this is your antecubital region. So you're on the outskirts of it, which is fine. So this one's fine. And then coming up, you have your median cubital vein, you have your cephalic vein, and your basilic vein. So as you can see, they branch. So a lot of you will hit this one. You'll start here, and then you're going to go right through it, right down the middle. So you got to know where it turns. So I'm going to say, where does it turn? Hey, it bifurcates. Where does it bifurcate? Make sure you pay attention to this. You have your basilic vein right here. This one's a good one too. So if you can find that one, then you can usually use it. All right, so what you need to start an IV, you need a wingtip or butterfly set. That's the most common. I don't typically, in outpatient, I'll use these only if I'm doing a hand injection where I don't need any kind of timing. So this I just inject by hand. I don't use a power injector with a butterfly. So, and then I'll use a needle where I can put a catheter in and leave it in. So most have a 6 to 12 inch tubing on these butterflies, which is really nice. There are some angiocath style butterflies that you can leave the plastic catheter in, and it has a hose on it, which is really nice. Very expensive. So typically the sites don't have those. All right, so venipuncture. The radiographer who performs venipuncture must be competent in technique so that the patient is not subjected to pain and the threat of injury or infection. So I'm going to teach you guys how to do it. Yes, you're going to practice on each other, which is a lot of fun. All right, so here's your sequence. You're going to make the patient comfortable. You're going to cleanse with an alcohol swab. You're going to isolate the vein and prepare for insertion. You're going to insert the needle. You're going to remove the tourniquet and inject the drug. Remove the needle after the injection. Apply pressure until bleeding stops and apply bandage. Dispose of the syringe and the needle in the sharps container and chart the information that you just did. So I'm going to show you this. There's a couple more steps in there because we don't just put a needle in and take it out. We put it in, we do the injection. So you have to tape it down, you have to remove the needle and just leave the plastic catheter in. So there's a few more steps to this, but you will be able to do it, I promise. So IV catheters. If you use an IV catheter to inject the solution, insert the needle next to the vein at a 15-degree angle and gently advance into the vein. Once a flash of blood is in the chamber of the catheter, lower the catheter parallel to the skin. Now it's going to be hard to remember all of this, and I'm going to help you. Advance the catheter before threading the flexible plastic portion of the catheter into the vein. Most catheters have a spring release, to retract the needle. Once the needle is retracted, blood will flow through. Advance the plastic sheath. Sorry, skipped one. Advance the plastic sheath of the catheter into the vein, pulling the needle back away from the sheath while maintaining taut pressure on the skin. And that's where you're going to hit the release of the spring loaded. The needle's going to retract back and you're going to have free flow of blood. So you got to act quick in order to get the hub on so that or your saline so that you're not dripping blood everywhere. So I'm going to show you tricks on how not to have blood spewing everywhere. All right, intravenous procedure. During and after venipuncture, it is important to watch for infiltration or exacerbation. If this occurs. So what it is where the contrast or saline is leaking out of the vein, okay? Strangulation occurs, remove the needle immediately, apply pressure to the injection site, and apply a warm, moist cloth to relieve the pain. So what that's going to do if you apply a warm cloth to the arm, it's going to dilate the blood vessels and help absorb that the fluid. So that helps. So some people say put cold on it so it decreases the pain and the swelling. Some people say warm. Do what your site says. I've seen both and I've argued both, so I don't know. So do not continue the injection. You need to stop the drug. So it's very corrosive and contrast will cause necrosis of the skin. So it's really important that you watch for this. If it's saline, it's not a corrosive drug like iodine is. So if iodine gets in there, we need to call the radiologist and probably plastic surgery to come in and take care of the patient. So charting. You need to put relevant information must be recorded in the patient's chart. Starting IV line, it must be sure to chart the number of injection attempts. So if it took you 5 times to get it, that's not good, and you need to chart it. If it only took you once, great, put it down. So you need to put the name of the drug, the dose of the drug, the route of administration, the date of administration, the time of administration, and the injection site, so that they are aware of what you did. So you've got to put that in the patient's chart. Technologists are held accountable for proper charting and documentation of a drug and contrast media. If errors or problems occur during any introduction of a drug or any adverse effects, full explanation should be in the chart. So technologist errors associated with drug administration are often litigated. So very important that you chart as much as you can, because we need to know what's happened. Sometimes we just fill out an incident report. That's easier. We'll put in the chart, you filled out incident report regarding infiltration, extravasation, approximately 100 cc's into the antecubital of iodine, omnipaque, blah, 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 blah. So, all right. So let's get into your chest tubes and your lines. So technologists often come in contact with patients who have endotracheal, central venous, or pulmonary artery lines. As a general understanding for placement of these devices is important for you to know. So we've gone through this before, but you need to be reminded what all of these lines are. So ET tubes or intubation. So they assist the patient through respiratory problems. So indications for the use of ET tubes include mechanical ventilation, oxygen delivery, and concerns about aspiration of stomach contents, upper airway obstruction, and administration of epinephrine during advanced cardiac life support. So inhaled air must be adequately humidified because of normal humidified function of the respiratory tract is bypass. You need to be able to suction these patients. So suctioning of secretions through the tube is required because normal pulsation of these secretions is impossible. Central venous catheters and venous access devices are catheters inserted into a large vein to administer drugs, manage fluids volumes, transfuse and analyze blood, and monitor pressures within the heart. So they can be available or inserted in percutaneous catheters, so they're subclavian insertion, totally implanted access ports, so infusive port or portacasts, and you'll hear a lot about portacasts. Peripherally inserted central venous catheters, there's externally tunneled catheters. So all of those are different central lines that we use to give medications to patients. The goal is to position the catheter tip in a central vein, usually the superior vena cava is where it ends up. So really important that you do not use these, and if you do, that you inject a heparinized saline so we can keep that line open and it doesn't clot off. All right, so pulmonary PA lines, normally we call them Swan-Ganz catheters. Specialized central venous line that incorporates a small electrode used to monitor pulmonary arterial pressures. PA lines are used to estimate left ventricular and diastolic pressure, and it's important that you know that there is a line going into the heart. You are not allowed to touch these lines. Stay away. All right. Complications in patient care. Central venous access devices can improve and extend quality of life, but complications can occur, such as catheter dislodgement. I've seen tips of these break off, not good. Occlusions resulting from accumulation of blood clots or drug residue on the tips of these. And clots break off and then they have a stroke, so that's not good. Care must be used when handling patients with central venous lines. This is why we assess patients before imaging procedures. Okay, so make sure you don't just place that line. Common abbreviations. So We use a lot of abbreviations. There are several listed within your book that show how often we give a drug. There's a lot of abbreviations. Now, they have to be approved abbreviations. You're not allowed to just make up your own abbreviations. So healthcare professionals who order, dispense, and administer drug often use abbreviations. Become familiar with the common abbreviations that are used is important to ensure a safe and accurate administration of drugs. So take a look at that list and make sure you know and understand exactly what they are. All right, that is your lecture.